In this video, we will cover colonic polyps and colonic adenocarcinoma. We will first cover some key terms, then discuss inflammatory polyps in the setting of solitary rectal ulcers, the different types of non-neoplastic polyps, and the syndromes in which they can arise. And finally, we will finish with the discussion of adenocarcinoma of the colon. To start, let's review some important terms. When we talk about a sessile lesion, we're just referring to a polyp or mass that doesn't have a stalk, so it's just kind of sitting on the wall of the colon. When we say pedunculated, we are referring to a polyp with a stalk. In other words, it looks like a lollipop. Non-neoplastic polyps are characterized by their histologic morphology and include adenomas, syndromes, FAP and HNPCC, and within FAP you have the variants Gardner syndrome and Turgot syndrome. Then you can also have inflammatory polyps and hamartomatous polyps, of which the syndromes associated with hamartomatous polyps include juvenile polypoesis syndrome, Peutz-Jeghers syndrome, tuberous sclerosis. And then the last type of non-neoplastic polyps we will discuss are the hyperplastic polyps. And of all of these, adenomas are the most common. So to start, solitary rectal ulcer syndrome is the triad of rectal bleeding, mucus discharge, and an inflammatory polyp at the anterior rectal wall. The polyp develops from impaired relaxation of the anal rectal sphincter, which results in recurrent abrasion and ulceration of the overlying rectal mucosa. This leads to cycles of injury and repair that will result in a polypoid mass of inflamed rectal tissue. Hamartomatous polyps are just tumor-like growths composed of mature cell types normally present at the site at which it develops. They can occur sporadically or as part of a genetically acquired syndrome, as in juvenile polypoesis, Peutz-Jeghers, or tuberous sclerosis. And over here on the right are just two examples of what a hamartomatous polyp looks like grossly and on histological exam. So juvenile polyps are the most common type of hamartomatous polyps and occur in children less than 5. While they can occur sporadically in adults, they are sometimes referred to confusingly as inflammatory polyps when there is a dense inflammatory infiltrate present. These can occur as part of the syndrome juvenile polyposis or sporadically. They are characteristically located in the rectum and grossly are pedunculated with cystic spaces on cut surface, and you can see that clearly in this picture. On histology, you can see dilated glands with mucin and inflammatory debris. Patients will often have rectal bleeding, or in some cases even prolapse of the polyp where they can feel it protruding through the anal rectal sphincter. Juvenile polypoesis is due to an autosomal dominant mutation in either the SMAD4 or BMPRIA that results in up to 100 juvenile polyps. Patients are usually less than 5 years old and have an increased risk of gastric, small intestinal, colonic, and pancreatic adenocarcinoma. Extraintestinal features include pulmonary arteriovenous malformations or digital clubbing. Colectomy can be required to limit hemorrhage associated with polyps ulceration. Peutz-Jeghers syndrome results from autosomal dominant germline heterozygous loss of function mutations in LKB1 or STK11. Clinically, patients present with multiple GI hamartomatous polyps, especially in the small intestine. On gross evaluation, the polyps are large and pedunculated. On histology, they form this characteristic arborizing network that you can see here. Patients also have characteristic hyperpigmentation of the mouth. There is an increased risk of colon, pancreas, breast, lung, gonadal, and uterine cancers in Peutz-Jeghers syndrome. Tuberous sclerosis is from an autosomal dominant mutation in the TSC1 or 2 gene and presents any time from infancy to adulthood. Patients can have rectal hamartomas, facial angiofibromas, cortical tumors or astrocytomas, and renal angiolipomas. Something they really like to test on is the cortical tumors, for which it was named, or other brain tumors such as the astrocytomas that are associated with this. Hyperplastic polyps are epithelial proliferations with no neoplastic potential that tend to occur in the 6th and 7th decade of life. They are thought to occur from decreased epithelial cell turnover and delayed shedding of the surface epithelial cells, which leads to a pile of these goblet cells and gives it this characteristic serrated appearance. These polyps tend to be located on the left side of the colon and on histological exam have a serrated surface that almost resembles a star, as you can see pictured here. Adenomas are benign polyps that give rise to most colorectal adenocarcinomas. In other words, they are the dysplastic precursor lesion. These are quite common. In the Western world, half of all adults greater than 50 will have an adenoma on colonoscopy. For this reason, it is recommended that patients undergo screening with colonoscopy beginning at age 50. However, if there is a positive family history of colon cancer, the first colonoscopy should be 10 years before the youngest relative was first diagnosed. Adenomas vary in size and shape from small pedunculated lesions to large sessile lesions. On histological exam, dysplastic features are present. These include darkening and elongation of the nucleus in addition to stratification. There is also a loss of epithelial maturation as cells migrate out of the crypt. Adenomas can be classified as either tubular, villous, or tubulovillous. Tubular adenomas tend to be small and pedunculated with rounded or tubular glands, as pictured in the top right. Villous adenomas are larger and often sessile with long, slender projections resembling the villi of the small intestine, as pictured in the middle. These are associated with more frequent foci of invasion. In other words, they have a higher risk of being malignant. Tubulovillous adenomas have characteristics of both tubular and villous adenomas. Sessile serrated adenomas are similar to hyperplastic polyps at first glance, but they have malignant potential. Unlike the other adenomas, they also lack the characteristic dysplastic features. These tend to occur in the right colon and also have a serrated architecture that extends to the base. This gives some of the glands a more boot-like shaped appearance, as you can see in the bottom right picture. Familial adenomatous polyposis, or FAP, is the syndrome associated with adenomas. It is also an autosomal dominant disorder due to a mutation in the adenomatous polyposis coli gene, or APC for short. Patients present with numerous colorectal adenomas by the teen years, and if left untreated, will develop adenocarcinoma by age 30. Patients can have other cancers as well. Because they will invariably develop cancer, they should undergo prophylactic colectomy before 30. Gardner syndrome also results from a mutation in the APC gene and is a variant of FAP. Patients have multiple adenomas, osteomas, dermoid tumors, thyroid tumors, dental abnormalities, and skin cysts. On the right, you can see an example of lipomas and some of the dental abnormalities that might arise. Turcotte syndrome is another variant of FAP. 2/3 of these patients will have a mutation in the APC gene, while the remaining 1/3 have mutations involved in DNA repair. In addition to adenomas, patients with Turcotte's have medulloblastomas and glioblastomas. The last syndrome we will discuss that is associated with adenomas is Lynch syndrome. It is also known as hereditary non-polyposis colorectal carcinoma. Patients have a germline mutation in genes encoding proteins involved in DNA mismatch repair. Patients will inherit one mutated allele and one normal allele. The normal allele is then lost through mutation or epigenetic silencing. As a result, defects in mismatch repair lead to accumulation of mutations in microsatellite regions, and this leads to microsatellite instability, which in turn results in cancers. As such, patients can present with multiple cancers, including colorectal, endometrial, stomach, ovarian, ureters, brain, small bowel, hepatobiliary tract, and skin. They also tend to present at a younger age than those with sporadic cancer, but older than those with FAP. Colonic cancers also tend to be right-sided in patients with HNPCC. So colonic adenocarcinoma is the most common malignancy of the GI tract and is the second most common cause of cancer-related deaths. It typically presents in people aged 60 to 70, and risk factors include a diet low in fiber and high in fats and carbs. Adenocarcinoma classically arises from a dysplastic adenoma precursor and follows one of two pathways of neoplastic transformation, either mutations in the APC or DNA mismatch repair genes. In the APC beta-catenin pathway, which accounts for 80% of sporadic colon tumors, the hallmark is chromosomal instability. So you start with the mutation of the APC gene, which is a negative regulator of beta-catenin and a component of the W&T signaling pathway. Beta-catenin activates transcription of MYC and cyclin D1, promoting proliferation. This was followed by activating mutations in KRAS, which promotes growth and prevents apoptosis. You then get loss of additional cancer suppressor genes, such as P53, LOH, SMAD2 and 4, in addition to overexertion of COX2. You then also get increased expression of telomerase. In the microsatellite instability pathway, there is DNA mismatch repair deficiency, and this is exemplified by the HNPCC. So mutations accumulate in microsatellite repeats. You can have mutations in the type 2 TGF-beta receptor, which is involved in cell growth regulation, in BAX, which is a pro-apoptotic protein, in BRAF, which is an oncogene, and you can also get methylation of MLH1. So on gross exam, adenocarcinoma can vary morphologically based on its location. In the proximal colon, they tend to form polypoid masses that extend into the lumen of the colon, as you can see pictured in the middle right. In the distal or left side of the colon, they tend to form these annular lesions that produce constriction. On X-ray, this gives the characteristic napkin ring or apple core finding, as pictured in the top right. On histology, you can appreciate tall columnar cells resembling the dysplastic epithelium or of adenomas with nuclear hyperchromasia and elongation and stratification. However, there will also be invasion, which results in a stromal desmoplastic result. So in this bottom right slide, what you can see is the upper portion is the neoplastic portion, and the bottom is the non-neoplastic. And there's this abrupt transition to the neoplastic process. Patient presentation also varies based on tumor location. Those with right-sided cancer will often present with iron deficiency anemia, and as such, in an older man or postmenopausal woman, iron deficiency anemia should be considered GI cancer until proven otherwise. Left-sided colon cancers present with occult rectal bleeding, on the other hand. They can also have constipation and pencil-thin stools, and this is the result of the way the tumor grows and constricts the lumen. The most important prognostic factors are depth of invasion and whether or not there are lymph node metastases. Poor differentiation and abundant mucin production on histology also indicate a worse prognosis. Adenocarcinoma does like to metastasize to the liver, regional lymph nodes, lungs, and bone. So that is it for this lecture.